We're next going to hear from Julia. She is a patient with APS1 hypoPARA.
Hi, my name is Julia. I've been managing autoimmune hypoPARA since 1983 as part of a rare genetic disorder called APS type 1. APS type 1 includes 3 classic manifestations, one of which is hypoPARA. The other 2 are Addison's disease and candidiasis. I have a combination of disorders with APS type 1 that complicate my hypoPARA management. It highlights the importance of improvements needed in treatment. I was 3 when I exhibited my first hypocalcemic seizure. Unfortunately, I was misdiagnosed with epilepsy. Most clinicians are unfamiliar with APS type 1, and affected children often present, as I did, to the emergency room with seizures due to severe hypocalcemia. They're often misdiagnosed with febrile seizures or epilepsy. As a preschooler, I continued to have seizures, laryngospasms, and then I developed cataracts. At the age of 5, so this is 2 years later, an ophthalmologist found the cataracts in both of my eyes and connected the cataracts to the past years of hypocalcemia. My best visual acuity at that time was 20/80 in each eye. The calcium deficiency had taken its toll. The ophthalmologist referred me to an endocrinologist who would then help to put the pieces together. Finally, I was diagnosed with hypoparathyroidism in 1985 at the age of 5. Finally, I began treatment for hypoPARA with calcitriol and calcium, the standard of care. This was the 80s. My cataracts were significant. The ophthalmologist had to remove both of the lenses in my eyes, so I now wear contacts and glasses, both, to achieve 20/25 vision in both eyes. Without these corrective lenses, I am legally blind. So as a child, I managed hypoPARA. I managed them with the other autoimmune disorders that I would develop. This was complicated. Until recently, I managed hypoPARA only with the standard of care, calcitriol and calcium. This medication was adequate. It doesn't replace the parathyroid hormone, though, with this disorder. It's the only autoimmune disorder that I have that does not have a direct hormone replacement. I often had varying high or low calcium symptoms, even while on the medication regimen. High levels caused increased urine output as calcium spills into my urine. This would show up in childhood as bedwetting. It's very humiliating and embarrassing. It showed up as incontinence. It showed up as kidney stones, and it increased my risk of further kidney stones. Low levels would cause other debilitating symptoms: numbness and tingling in the hands and the feet to varying degrees depending on the level, decreased muscle strength. This inhibits physical activity, as you've heard, altered mood, irritability, brain fog, difficulty concentrating, and then as they got more severe, you get the tetany, and that's painful. You can imagine what those symptoms, how they affect your life, including difficulty walking, climbing stairs. Into adulthood, it was difficulty carrying my children, carrying anything. Accomplishing tasks with efficiency that require concentration was also difficult. So I try to be proactive. I try to manage my highs and lows. I try to prevent the severity, the extreme swings. I get outpatient labs when I notice symptoms start to appear. I adjusted my medication at home when possible. I couldn't always avoid hospitalization. Wide fluctuations can still occur with standard of care. My lowest level was 4.8. My highest level has been 13.0. Those are extreme, and those are very dangerous. Managing hypoPARA with other autoimmune diseases, as I've said, is complex and it's difficult. I'm not above a challenge. I will do everything I can to manage this. I was often hospitalized with hypocalcemia when I would acquire upper respiratory infections, stomach viruses, bacterial and viruses. Any trauma or stress to the body requires additional steroid management for Addison's disease, which I also have. This steroid management further has an unintended consequence of lowering my calcium as well. Calcium absorption was then hindered after a diagnosis of pernicious anemia, another autoimmune cause for that. Gastritis would ensue during my 20s. This would also affect my absorption of calcium. The gastritis is what is thought to have led to my stomach cancer in 2013. The removal of my stomach in 2013 also hindered my calcium absorption, so you can see how this is all complicated. I continued to face even more difficulties absorbing all of my medications, but specifically, I didn't absorb calcium or oral calcium well. These require acidity. They also require a stomach. I don't have that. Between 2013 and 2015, after my total gastrectomy, while still on the standard of care, calcitriol and calcium, I was hospitalized on average 4 times a year, weekly hospitalizations, due to critically low calcium. This oral medication regimen was not ideal. It continues to miss the mark, but it was all I had. It was my only option. I've lived my life with this mediocre management because I had no other options, until NatPara came out in 2015. When I began using NatPara in 2015, it was life-changing for me, life-changing for my family. I know what my quality of life can be like now. The wide fluctuations have ceased. The symptoms are not as severe. My quality of life is drastically improved. I could explain more, but I'll leave it at that. I'm still on NatPara right now through a compassionate use program. It will be done at the end of 2024. I do not want to go back to standard therapy. I don't want to average 4 hospitalizations a year. These are the acute symptoms that I feel every day that I've talked about, but there are long-term symptoms as well. I've had hypoPARA for 40 years. So the standard of care and the disease have taken its toll. They cause unseen damage to the body. My bones have significantly weakened over the years, as evidenced by DEXA scans. I now have osteoporosis. A simple fall leads to a fracture. This occurred in January. I fell and broke my wrist. 2 bones broken, required surgery. My kidneys have been taxed with calciuria, so they're showing signs of damage. My body is full of calcifications, even in my brain. While the window to build bone has passed, I still have power. I have power to slow the decline of bone. I have power to limit the calcium that spills in my urine. I have power to seek help. I have power to implore you to research direct parathyroid hormone placement. I have power to push for the therapy that I need and others need. I need this rather than the standard of care of vitamin D and calcium. Those with APS type 1 that are diagnosed with hypoPARA at an early age and have a full life ahead of them need hope that there are health outcomes that are better than we have achieved in the past. They don't need to fear long-term health effects of poorly managed calcium. Thank you.
Thank you, Julia. The rare of the rare just gave us some really great details around APS1. Thank you so much.